It's a pleasure to introduce my colleague and friend, Andrea LaCroix. She is the Distinguished Professor and the Chief of Epidemiology in the new Herbert Wertheim School of Public Health and Human Longevity Science, University of California, San Diego. Her educational preparation began with a master's and a PhD in epidemiology at the University of North Carolina, and then was followed with a postdoc in cardiovascular epidemiology at the Johns Hopkins University. Her early employment as an epidemiologist for the National Center for Health Statistics and the National Institute on Aging provided her opportunities to work on measurement techniques and participate in early cohort studies of aging. She also made major contributions to science in other institutions, including the University of Washington, Kaiser Group Health Research Institute, and the Fred Hutchinson Cancer Research Center. It was here where she served as the co-project director of the Women's Health Initiative Clinical Coordinating Center, and she continued as a Women's Health Initiative investigator for over 27 years. Dr. LaCroix's scientific research has shifted many paradigms in women's health, in aging, in exercise, and the frailty associated with aging. Dr. LaCroix serves on the board of the Scientific Counselors for the National Institute on Aging and is on a study section for aging and the Clinical Trials Review Panel. She's authored over 500 scientific publications and mentored over 50 doctoral, postdoctoral, fellows, and K awardees. It is my great pleasure to introduce you to Andrea LaCroix, who will address supporting midlife women in the menopause transition, MsFLASH and the Individualized Menopause Plans. Andrea?
Thank you so much, Dr. Reiber. And in full disclosure to the audience, I want to note that Dr. Reiber and I are longtime friends, and I'm privileged to have her in my immediate audience today, and have been privileged to have Dr. Reiber as my exercise buddy and my healthy aging buddy. And most especially, I do believe we went through the menopause transition at different times during our friendship. Perhaps some of today's talk will bring back some memories. I want to give you some brief background, which will come as no news to you, that the vast majority of women in midlife experience vasomotor symptoms. Over 38 million US women in the age group 45 to 64. It is not an uncommon symptom to have hot flashes or night sweats. And hot flashes and night sweats, as only one of many menopause symptoms that can be experienced, can impact on our daily living in numerous ways, affecting how we work, our social and leisure activities, sleep, mood, and concentration, sexual activity, and energy levels. And I can recall walks at Pike Place Market with Dr. Reiber, in which we decided to purchase something exciting. And as I signed the credit card slip, just having sweat drip off my face right onto the credit receipt. But still we survived. So I wanted to first make the point to you that menopause has been very much in the news, and there have been numerous articles that have been published during the pandemic about women's experience of menopause in the isolation of the pandemic. One of these articles, this one on the right by Jackie Gillard, who's from Toronto, talks about what it was like for her to be at home with her family experiencing menopause. I think this is a great article because she articulates that whereas she would have not been so out there with her family having these symptoms, going through this experience with her family all around her enabled them to see what was happening, created some discussion. And ultimately, at the end of the article, she articulates that now that her family knows that she's going through this and that the duration is not too short. I mean, for many women, the menopause transition can take a number of years, that there's just been a more compassionate reception to what she's going through in her family. And I just start with that kind of take on experiencing menopause, because a little compassion, although we won't be talking about that specifically as a treatment today, can go a long way in making the transition more comfortable for women at home with their families. So I wanted to start by saying that the background for much of what we'll talk about today does come from the Women's Health Initiative. And the finding from the Women's Health Initiative that estrogen plus progestin in the most common dose that was taken prior to the publication of the earliest WHI findings in 2002 showed a number of risks that we didn't know about before the WHI associated with taking hormone therapy. And before that, we really thought that hormone therapy might be broadly beneficial, including for heart disease. We didn't know for sure about the risks and benefits of breast cancer. And we did know that it likely reduced the risk of fracture. But altogether, this news was unwelcome that there were so many risks. If the WHI had revealed overall broad beneficial preventive effects of taking hormone therapy starting in midlife, we probably wouldn't be having this same conversation today, because if it were safe to take this medicine, it's very effective for hot flashes and night sweats, some other symptoms of menopause. If it were a low risk intervention, it would be not necessary to have investigated all these other ways of treating menopause symptoms. But Bernadine Healy, who was responsible for starting the Women's Health Initiative when she was director of the NIH, recognized the importance of the mixed results from the WHI on risks and benefits. And when she was interviewed in 2011, not too long before her death, she said, "Women have to understand that their health and well-being is affected and determined by personal choices. That includes personal medical choices. There's not one medication or one practice that suits all." And what happened after the WHI was that there was a call to find new ways to manage menopause symptoms so that the repertoire would be greater than just hormone therapy. And so the NIH issued a request for proposals, an RFP, to create a network that would bring together trialists from across the country with expertise in menopause to find new ways to alleviate the most common bothersome symptoms of the menopausal transition by designing and conducting multiple concurrent clinical intervention studies, accommodating a wide scope of populations and intervention strategies. And we competed for that many years ago, approximately, I'm thinking this happened in 2007 or 8. And we were awarded the network, which we named MsFLASH. MsFLASH stands for Menopause Strategies, Finding Lasting Answers for Symptoms and Health. And so one of the special things about this network is that it was funded by the NIH. And so much of what you hear and read about related to menopause symptoms is really funded by pharma. Women are a huge market for anything that might help with managing menopause symptoms. And very little of that information that we get is from unbiased NIH-funded sources where we're not trying to sell women anything. We're just trying to get rigorous evidence to improve the basis of their decision-making. So this network was funded by several places at NIH. You can see the NICHD, NCAM, the Office of Research on Women's Health, and the main funder, the National Institute on Aging, all collaborated. And then after the first funding period, we competed for an R01 grant to extend this work. And that grant is currently in its second no-cost extension. It's called MsFLASH, Living a Healthy Menopause. And the MyMeno plan digital resource that I'll be sharing with you today is part of this R01, as well as a large, well-conducted vaginal health trial. So the first 3 MsFLASH trials, I'll be showing you some comparative data from these. The first MsFLASH trial looked at escitalopram, SSRI antidepressant, versus placebo. The second one was a 3x2 factorial design, assigning women to exercise or yoga versus a behavioral control group. And for the 2 part of the 3x2 factorial design, assigning them randomly to omega-3 versus placebo. So there's actually 6 different groups in MsFLASH 2. And then in MsFLASH 3, we compared low-dose estradiol or venlafaxine, a SNRI antidepressant, to placebo. And we're now able to combine the results from all 3 of these trials to compare the treatment effects on a variety of menopause symptoms from these studies. We put in place common eligibility criteria to make these joint analyses possible. So all women in the MsFLASH trials are aged 40 to 62 years. They were in the menopause transition or postmenopausal. All of them had to have at least 14 hot flashes per week, so an average of 2 or more per day, with at least some rated as bothersome or severe. They had to be in general good health and sign informed consent. I want to just share with you briefly a couple of special things about the MsFLASH trials. And one of them is that hot flash inclusion criteria. The FDA has a guidance document for pharma that requires an average of 7 or more hot flashes per day for pharma to comply with in their trials of menopause treatments. And when you actually look at the number of hot flashes experienced by midlife women in the United States, it's a very small percentage of the population that experiences 7 or more hot flashes or night sweats per day. And of course, these could be added together. Many, many more women experience a couple a day. So we decided in this NIH-funded network, where we weren't trying to register any new medicines for increasing the market share of anything, that we could be more inclusive. So we set the eligibility criteria at least 14. In MsFLASH 01, we actually started with 28 hot flashes, or an average of 4 per week, still quite a bit lower than the 7 that pharma must comply with. And then we decreased it because it turns out that you're excluding a large number of women, as you could see from the previous slide, who don't even have an average of 4 hot flashes a day. So our common eligibility criteria is quite inclusive of the women who are experiencing vasomotor symptoms. Other differences between these first 3 trials is that trials 1 and 3 on the medications were 8 weeks long, and trial 2 was 12 weeks long. We reasoned that medical pill interventions would be quicker to influence hot flashes than behavioral interventions like exercise or yoga. We assess vasomotor symptoms with daily diaries every week for studies 1 and 3, the medication studies, but only at 6 and 12 weeks for study 2. And that was because we were asking the women to do yoga or exercise or a behavioral control. And since we were already burdening them with those interventions, we didn't want them to have to complete diaries every day. And then in MsFLASH 2, which was the behavioral trial, we also excluded women with regular exercise or yoga practice so that they would be randomized to something that they weren't already doing. So a few other special things about the MsFLASH network is that when you look at the US data, we know that African-American women have a higher percentage of women experiencing vasomotor symptoms than other race ethnic groups. And we also know that their symptoms are more severe. So it was very important to include African-American and Hispanic women that were severely underrepresented in vasomotor symptom trials before MsFLASH. And you can see in this slide that we succeeded. Our goal was to include half African-American women in MsFLASH 1. And you can see we did have half minority women in MsFLASH 1. And in the other 2 trials, we still had a very healthy representation of African-American women. It was very, very important in our network trials and very uncommon in other trials. So let's just look at some summary of our trial results. In the data that I'm about to show you, we're combining data from 3 or 4 MsFLASH trials in a pooled analysis. This pooled analysis looks at individual level data from all the trials combined using a rigorous statistical methodology, and it accounts for the differences in the trials I've told you about. These are the statistical methods, which I will not go over with you in detail, but you can look at them in our papers and ask questions later if you have them. And that's just a reminder of what 1, 2, and 3 go with, because we're about to look at 1, 2, and 3 as the shorthand for these trials. So here you see the characteristics of women in each of the MsFLASH trials. And the average age was around 54 to 55 in all the trials, but there was definitely spread across this age group. We've already looked at the race ethnicity data. Education was also reasonably diverse. So while there were many women with a college graduate, in some of the trials, half of the women did not have that. In all of the trials, there were some women who were only high school graduates. So lots of diversity. There were plenty of smokers, current and past. Body mass index, like the US, in general. Yesterday or the other day, I read that 70% of Americans are in the overweight or obesity range. That pretty much holds for the MsFLASH trial participants too. Kind of makes you think that we drew the line in the wrong place, doesn't it? But that's a topic for another day. So in terms of menopause status, around 69 to 76% of women were postmenopausal, and the rest were perimenopausal, or we could not determine their menopausal status, likely because of hysterectomy. This just shows you the sites that participated and the average number of hot flashes in each of these trials. So we're in the trial that had the highest threshold of 28 per week. We got just under 9 hot flashes on average. But in the other 2 trials, also a large number of hot flashes on average daily, 7.6 in MsFLASH 02 and 8.1 in MsFLASH 3. And these are bother rating scores, very similar across the trials. So let's compare from these trials, what are the effects of these interventions on vasomotor symptom frequency and bother? This slide shows changes from baseline in vasomotor symptom frequency. This is hot flashes and night sweats summarized. And this line here, this dark black line, is the 0 point. So this would mean no change. You can see that for omega-3, it actually didn't reduce hot flashes at all. If anything, it slightly increased them. So omega-3 was our ideal placebo. It just didn't help at all. In the next, you see exercise, also very null. Exercise did not help with hot flashes. It helps with a great many other things, but not with hot flashes and night sweats. And then this green line is yoga. So there was some signal here, tiny, that yoga might help reduce hot flashes. But the winners for vasomotor symptoms were all medications. And so you'll note here that estradiol in the blue line was the most effective, and this is low dose estradiol in MsFLASH 03, not the standard dose, was the most effective in reducing hot flashes. And venlafaxine and escitalopram, the 2 antidepressants, were similarly effective. And the other thing to notice about this, though, is that they're not that different. And so when we look at bother, I'll come back with a summary in a minute. We see a similar pattern of results where the medications are the most effective. Here we see that venlafaxine is a little bit less effective than escitalopram, not significantly so, but all these medicines seem to be helpful. And if we look at clinical improvement defined as at least 50% improvement from baseline in vasomotor symptom frequency in the 3 pill trials, we really see very, very comparable results. So at week 4, escitalopram. All three of these were resulted in 40 to 44% improvement. And by week 8, we can see that estrogen has edged a tiny bit the this degree of clinical improvement, but these are very, very comparable interventions, something that we didn't know before doing these trials. So in summary, after adjustment for baseline characteristics and outcome values, outcome measures, the effects of all medications were similarly beneficial for vasomotor symptom frequency and bother. And in these trials, all study medications were well tolerated. Let's move on to the second most common and bothersome symptom in the menopause sphere, which is insomnia symptoms and sleep quality. And for this next set of pooled results, joint results, I'm going to show you the data only in women who had an insomnia severity index of at least 12, which identifies women with significant, clinically significant insomnia symptoms. We're able to do that. We use 2 measures in these sleep outcomes. One is the Insomnia Severity Index, which is a very well validated and reliable instrument where the scores range from 0 to 28. And all the data that you'll see coming up is in women that had a score of at least 12. And then we also look at the Pittsburgh Sleep Quality Index called the PSQI. This is a validated measure of subjective sleep quality and sleep disturbances over a 1-month time period. And the global PSQI score range is 0 to 21. To the first 3 MsFLASH trials in the data that you're about to see, we add a 4th trial, which was MsFLASH 04. And it was a randomized controlled trial of telephone-based cognitive behavioral training for insomnia in midlife women with vasomotor symptoms. And this was published in JAMA Internal Medicine a few years ago. Very good paper, very important paper. And I'll show you, I highly recommend, everything I'm showing you today has been published. Charles Moran is a Canadian who designed CBT for insomnia cognitive behavioral therapy and was a close consultant on this project. And this just shows you the design of that telephone-based cognitive behavioral intervention. 53 women were randomly assigned to the cognitive behavioral therapy intervention. The other 53 were randomly assigned to a menopause education control with an equivalent amount of phone time with a counselor. And both groups received this 20 to 30-minute telephone call each week with an interventionist. Both completed daily sleep logs. And both were given a booklet called Menopause Time for a Change from the NIA, and they had group-specific additional reading materials. So that adds another treatment to our graphs here, and it's shown in pink. And what you can immediately see here is, so again, the winner for the least effective intervention is omega-3 tablets. So fish oil not helping us. In the red line up here. And the next, everything else had some decrease from baseline. The next lines are for yoga and actually estradiol and exercise, kind of grouping together, but not far away is escitalopram and venlafaxine. So I think we would say that all of these interventions showed a little benefit, but not much. And the clear winner when you compare in joint analyses what helps women with insomnia is cognitive behavioral therapy for insomnia that can be delivered on the telephone. And you can also do it yourself with online programs. We haven't tested that, and we think that being accountable to a telephone counselor is likely much more effective. But we really need to be disseminating and translating this finding right here on CBTI, which could help so many women. And the same pattern of results for sleep quality with the PSQI. You can see that far and away, cognitive behavioral therapy was more beneficial than any other intervention. If we look at the odds ratios of remission to an ISI, an Insomnia Severity Index score less than 8 from where the women started, this just plays out the same way. And we see that omega-3, resulted in no improvement, and that there are these small improvements for all the other interventions, and that the largest amount of remission of insomnia symptoms occurred. The odds ratio, this is an odds ratio of 8-fold compared to the null value if a woman was randomized to CBTI. I think that's really quite phenomenal. And so, summary of intervention effects here. CBTI is the most effective intervention for improving insomnia and sleep quality in midlife women bothered by insomnia symptoms. Escitalopram and venlafaxine were modestly effective. Yoga and exercise also potentially helpful for sleep outcomes with small treatment effects. And estradiol's effect on sleep quality was comparable to the other medicines. Now let's talk more broadly again about quality of life. And for this, we use a validated instrument called the MENQOL, developed by Hilditch and Lewis. This is 29 questionnaire items. There's an overall score and then 4 domains for vasomotor, psychosocial, physical, and sexual scores within the scale. Each scale score ranges from 1 to 8, with higher scores indicating more symptoms or more bothersome symptoms. And this just shows you the kind of items in each of the subscales. So vasomotor, very much focused on hot flashes and night sweats. They say flushes, the Brits say flushes, and Hilditch and Lewis are Brits, so here you get the flushes. Psychosocial includes anxiety, memory, feeling blue. Physical includes this variety of physical symptoms that women in the midlife complain about. And sexual includes sexual desire, vaginal dryness, and intimacy problems. So when we look at the total MENQOL and compare the first 3 MsFLASH trials, what we see clearly here is that estradiol in the total MENQOL, estradiol and escitalopram have very comparable and small but beneficial treatment effects. The next most beneficial intervention was actually yoga, and with venlafaxine comparable to yoga at 8 weeks of follow-up, and the other 2 interventions not helpful for the total MENQOL. And when we just look at vasomotor, it won't surprise you to see that even with low-dose estradiol, we get a stronger signal that low-dose estradiol reduced vasomotor symptoms, stronger than for any other intervention. When we look at psychosocial, we see that the 2 antidepressants, venlafaxine and escitalopram, improve psychosocial the most, that estrogen seemed not to be too helpful with psychosocial problems at 8 weeks, and the other interventions were quite null. And then for physical symptoms, and this is that sort of mixed bag of problems of symptoms that women complain about, we didn't really see a strong signal that any of the interventions were extremely helpful. But it looks like exercise speaks more for the physical than it did for any other thing, and yoga as well. And all the medicine interventions helped a little, just not more than exercise and not more than yoga. And then for sexual, it's kind of funny. Yoga's good for the sexual MENQOL. Maybe it makes us more limber. Maybe it makes us have more energy. Maybe it makes us have more libido from just the meditative aspects of it. Estradiol also helpful for the sexual MENQOL. The next most was escitalopram, and it's good to see for the sexual MENQOL that the 2 antidepressants did not harm sexual function. So I just point that out here as well. This slide summarizes the magnitude of the intervention effects for all these different things we've talked about. And you can see that the magnitude, these are score changes on average. And you can see that the magnitude is modest. I think it's interesting that even estradiol on vasomotor symptoms is only resulting in a small change on the scale score. But we still think from the qualitative reports about benefits and relief from symptoms that many women appreciated all of these different interventions for different things. So a summary: after adjustment for baseline characteristics and outcome measure values, escitalopram, estradiol, and yoga were modestly effective at improving total MENQOL scores. Estradiol was the most effective at improving vasomotor MENQOL. Escitalopram was most effective at improving the psychosocial MENQOL, and yoga and estradiol were equally effective in improving the sexual MENQOL scores. So now I would like to give you a guided tour through showing you a video that Catherine Newton and I made about a week ago about this menopause website, digital resource that we've been working very hard on as part of the current R01. And this is the MyMeno Plan website. And our goal in this aim of the R01 was to review 25 years, all the available evidence, including the MsFLASH trials, and to develop and pilot test a comprehensive state-of-the-art multimedia digital resource to translate and disseminate rigorous trial evidence, such as what I just showed you, to assist women in making personalized, informed decisions for managing menopause symptoms. So I hope you'll enjoy this guided tour, and we'll come back together when it's over. I apologize in advance for any rockiness getting from the video back to you, but let's take a look at this so that you can see what it is this website is doing. Before I click on the link here to show you the video, I want to say that we're currently in a beta testing phase. We hope to release the website to the internet in 2021, and we are looking for dissemination partners to use this website in a practice setting. If anybody's interested in helping with that in your various practices, I would love to hear from you. So with that, here we go. And I must apologize also for the fact that we are not actors, and so you're getting a guided tour that's two lovely researchers talking about their work without any glitz or polish here. Here we go. This is Andrea LaCroix from Cardiff, California, near San Diego, and we have with us Dr. Catherine Newton from Whidbey Island, near Seattle, Washington. We are preparing this brief video to show you this morning to give you a guided tour of the MyMeno Plan website. This is aim 2 of our R01, which we've been working on now for several years during this funding cycle. And what the purpose of this mobile resource is to provide a comprehensive and accurate evidence-based resource for women to help them understand and make informed decisions about their plan for managing menopause symptoms. It is also intended to provide healthcare providers and physicians with a way to more easily counsel women going through the menopause transition by allowing them to explore their options before, during, and after their encounters with their physicians. So we hope you enjoy this tour and have a good meeting today. Dr. Newton?
Thanks, Andrea. So I'm delighted to show you our site today. I'm going to share my screen. So this is the opening page of the MyMeno Plan website with our logo there, our MP logo. And you'll see that the site has 6 landing pages people can go to, in addition to the opening page. And on the opening page, in addition to these pictures of women, women can go to 3 sections. They can go to what is menopause, our video, and create your menopause plan, which is really the heart of the program. So we wanted to put those on the opening page. But if they go to the About Menopause section, there are 6 places they can then go. One is a menopause Q&A. We actually have a tool where they can find out what stage of menopause they're in. strategies for talking to their doctor, information for women who've had breast cancer. And we think this is a really unique addition to this site, is information for transgender and non-binary people and staying healthy in midlife. The tool allows a woman to go through and answer a series of questions. For example, have you had a period in the last 12 months? What's happening to their cycles? And based on their answers, and we did this based on the STRA criteria, they get an answer about their reproductive stage, and they can also link to the facts. The Staying in Healthy and Midlife Women section lists the kinds of areas that you might think about that women might have questions about, but rather than trying to develop these ourselves, we link women to mostly federal sites, the CDC and NIH websites, where they can get more information about these issues. The symptoms page lists all the symptoms here, and women can see them in the pull-down menu, or they can click on the symptoms page. And we've organized symptoms into 3 areas. The 3 most common: vaginal symptoms and other kinds of symptoms. So for example, in the symptoms, if a woman has hot flashes and night sweats, she can click on that. And this symptom page, when it comes up, will show you the format that we used for all our symptom pages. It's being a little pokey right now. Maybe I'll try again. Let me try a different symptom. So if, for example, we show you mood, depression, and anxiety, there we go. On this page, we start out with trying to help women decide if they need to talk to a doctor. But on all the pages, we have what's happening to my body and what to expect, and then treatments that help, that may help, that don't help, that may hurt, etc. And so women can scroll down and see this, and they can link to treatments that we have on our treatments page. They can also complete a diary to track their moods, and they can click on brief screening tools that will give them answers to screening questionnaires and advise them when they need to consider seeing a health professional. Let's see if we can bring up hot flashes. There we go. So here's the hot flash and night sweat page. And again, we talk about what it is, what's happening to their body. There's a diary where they can track their hot flashes if they want. They can print that diary to record their number and how bothered or how severe they thought their hot flashes were, and what to expect, etc. The next landing page is for treatments, and we've grouped those into 6 categories for women to explore. And we group them into prescriptions, supplements, and over-the-counter, things where they really need professional help or might seek professional help, mind-body wellness, other things they can try on their own. And then for symptoms where there were a wide variety of things they might try, but where we hadn't really studied those specifically one at a time, we have symptom pages that list, treatment pages that list things they might try for those symptoms. So for example, if we go to the hormone therapy page, we talk about, first of all, what that treatment is, and then the bottom line that we came to in our reviews, and then we list the symptoms it helps for, may helps for, doesn't help for. We talk about risks and side effects and quality of life and what to do if they want to try that treatment. And on every page, they can print the page if they want, or they can go directly to the Create My Menopause plan page. So this is an example of what we do. Our bottom line doesn't help, and then the symptoms it helps for, that it might help for, that research shows it probably doesn't help for, and potential risks, etc. Another example for treatments might be yoga. Again, so what it is, our bottom line, what it might help for, potential risks, and what to do if they want to try it. And we also say at the bottom what that treatment is not used for or not studied for. And we also, at the bottom of all our pages, have references. The women's stories are still a work in progress, but the Your Meno Plan is really the heart and soul of this website. On this page, women can pick symptoms that they're interested in or that they're having and see what treatments there are in a grid. So for example, if I'm having hot flashes and mood issues, I click on those, and then I get the treatments. I go down, and here it is. It says what treatments may help or are thought to help for those symptoms. So what if I'm not interested in taking any prescription medicines? Or let's say I'm just interested in things I can try on my own, and I've had breast cancer. You can click on those and it will filter and only show you the things that are appropriate for women who've had breast cancer who are interested in managing those symptoms. And if I'm only interested in treatments that research knows they help, I can click on that and I'll only see the treatments that help. And I can click on any treatment to go see more about it. And women can print this page to take it to their doctor. Other filters that we have are, for example, maybe I'm only interested in mind-body wellness, or I'd like the help of a professional, or I'm only interested in foods, herbs, over the counter. Women can filter by all those things. And the last landing page is who we are. Again, we have 6 sections on this. In our story, we tell women about our background as researchers and why we did this work. And this is where we really stress where our funding comes from. We're not trying to sell people anything, and where our funding came from. If they're interested more in who we are, they can go to Our Team landing page and see us. They can click, for example, they can click on Andrea to find out more about who she is, and we describe more in depth. And we also can go view their academic profile if women are interested. This was actually something they asked for. The women who were in some of our beta testing asked for that. They said, I want to know more about this person. In our video, we tell something about who we are. We describe a little bit about our own menopause experience and why we really wanted to make this site, what we thought is important for women to know.
I'm Andrea LaCroix. Right now I'm Professor and Chief of Epidemiology at the University of California, San Diego.
My name is Catherine Newton, and I am a chronic disease epidemiologist. So I'm Susan Reed. I am currently a professor and vice chair for research at the University of Washington in Seattle, Washington.
And my name is Christine Andrew, and I'm a general internist.
So we describe ourselves.
And to do these kind of studies by proposing the best science. And we just feel so strongly now that the most important thing is that you all benefit from it.
Most women go through it fine. They have some symptoms, but it's a natural event. They're going to get through it and they'll come out of it and they're going to be just fine.
Actually went through menopause natural.
I went through menopause naturally, but I had a hysterectomy when I was 44.
So that gives you an idea of the kinds of stories that we tell on this website and in the video. And then we put all of the MsFLASH publications on this site with links to the PDFs. And we have a section on the science. And this is for women who really are interested in, well, what did you do? How did you decide? So on this site, we talk about the review process and how we reviewed the literature. We talked about how we graded the evidence and more about what we thought was important in how we evaluated the evidence. And then we go into describing about randomized trials, what they are, and the placebo effect, because the placebo effect is such a strong factor in studies on menopause. We thought some women might be interested in knowing more about that, and again, references. And then there's a section where women can contact us, not with medical questions, but if they want to give us feedback about the site or have non-medical questions for us. So that's the MyMeno Plan website.
Thank you so much for viewing this very lay video that Catherine and I are sharing with you. We look forward to sharing a very refined website. We're still working out little things and beta testing and working on a number of different pilot tests, but we're very excited to share this with women and hope to partner with you to do so. So have a great meeting and come again. Bye-bye. Dale, we're back together and I've stopped everything.
Great.
Hopefully you can hear me. I just want to thank everyone for taking the guided tour of the MyMeno Plan website, and I look forward to answering your questions and getting back together with you in real life to the extent we're able to. Thank you so much.